heart here. Complications from any heart disease as a whole. So when we're talking about heart disease as a whole, and we talked about earlier, we want the patient hemodynamically stable. So that across the board means that we need the cardiac output to equal the stroke volume times heart rate. The preloads, the afterloads, we mentioned contractility. There's a handout in your canvas that talks about Swan-Ganz. So it looks like this, okay? Make sure you brief it. One thing about what a Swan-Ganz does is you see that it has a bunch of stuff. One thing about the stuff that we mentioned, it has a balloon that should always be deflated unless you're checking that pulmonary artery pressure, also known as a wedge pressure, like a wedge, cheese wedge, kind of same thing. And what it does is it's measuring really truly the volume the patient has. The volume, so it's all about volume. And volume is important, again, when it comes to perfusion. So this is just a quick little handout for you guys to see that. When patients have Swan-Ganz, it really is these patients probably had multiple bypasses or they're not hemodynamically stable. These patients are usually a little bit more critical because we have to monitor them closely to make sure that we can get them back to perfusion well, right? So if not, then heart failure develops. We know by the aging heart that heart failure develops. We talked about that already too as well. So leading to the heart failures, we know that we have patients that are either pink puffers or blue bloaters, right, symptoms-wise. So the right-sided heart failure patient are your blue bloaters. What do they have? Peripheral edema, lower leg extremity edema. What else do they have? Blue bloaters. JVD, jugular vein distension. What else? Two more things I'm looking for. Ascites. So that it's fluid in the abdominal cavity. One more thing.
Weight gain.
Weight gain, we also know as what? But we also know that there could also be one more thing with all of that. Fluid overload, yes. Anasarca, remember? Generalized head to toe edema. Generalized head to toe edema. Anasarca, fancy way to say it. So our left-sided, what do they look like? Crackles because of what?
Pulmonary edema.
Pulmonary edema, yep, fluid in the lungs. So that's two things we got covered. Two more things we're looking for. With the crackles comes along, so coughing up the sputum, but they're short of breath, right? That's why they would want to cough. So then we're looking for one more thing. What was that?
I don't know, I guess.
Okay. Fatigue, yes, that could happen, but that's not what I was looking for. Anybody will be fatigued if they can't breathe, so that's kind of self-explanatory there. One more thing I'm looking for. Opposite. Polycythemia. Remember that word? Polycythemia. Poly meaning many, cells that are red. So many red blood cells. Remember there's a disease process called polycythemia vera, and that's an overproduction of red blood cells. When a patient is trying to compensate, they develop more red blood cells. So that's premature, trying to help carry that oxygen, right? With the hemoglobin, et cetera, et cetera. So they become polycythemia, so they're pink. That's why we call them pink puffers. Okay? So, one thing to think about with these, yes, is the weight gain. So we would definitely want to do daily weights on the patient. Same time, same type of clothing, right? The other thing that we have to think about with these patients is a lot of this occurs over the age of 65. They're more susceptible, again, for the decrease in function. And then, how do we measure how congested they are? What is that, those magic letters?
Ejection fraction?
Ejection fraction will tell me how well their left ventricle or how not so well that left ventricle is doing. But what is the laboratory test that we can do? Because that's an echocardiogram. BNP. The BNP measures how much fluid is on board for that patient. When a patient tells you that they can't lie flat, that's probably a pretty good sign that they're having some heart failure or overload issues as a whole. So that is a sign we need to get the BNP, maybe order an echocardiogram to see what that ejection fraction really is. When we're looking at the classifications, D is the worst. Severe congestion, no, not going anything back. So 1 is to eliminate those signs and symptoms for heart failure, and 2 is to improve the function, to extend the survival. The treatment is all based on severity, first and foremost. So when we're looking at medications to treat the heart failure, one thing we have is our ACE inhibitors. What do ACE inhibitors do? What are the 2 functions of an ACE inhibitor to help with heart failure?
This angiotensin converting enzyme, so
It's inhibiting what from happening?
the lungs from converting the angiotensin.
But what is happening to that patient? What is it inhibiting? You're right, it's
Sympathetic.
way too deep.
Oh, okay.
What is being inhibited by that conversion not happening?
Fluid retention?
One more time, Mike.
Fluid retention?
Well,
So
yes.
Like you're promoting diuresis,
It
basically.
is promoting diuresis, so that's one thing it's doing. But when angiotensin 1 happens to angiotensin 2, what happens? Vasoconstriction. So by giving ACE inhibitor, I'm inhibiting vasoconstriction. And I'm promoting diuresing. So that's the 2 functions of an ACE inhibitor, is inhibiting vasoconstriction and promoting diuresing. In the world of our ARBs, or angiotensin 2 receptor blockers, what is the 2 functions? Promoting diuresing and inhibiting vasoconstriction. The only difference between an ACE and an ARB is it's done at a different place. It's blocking the receptor, so that angiotensin 2 never gets to that receptor to cause vasoconstriction. In our world of calcium channel blockers, a little dab will do ya. Work smarter, not harder. Decreases the O2 demands. Beta blockers, we said earlier, decreases preload and afterload and helps with contractility, which in turn then decreases heart rate. That's why there's parameters on beta blockers. Systolics less than 90 and a heart rate less than 60. We do not give beta blockers. And that's the reason why. Diuretics. I think that's self-explanatory, right? Pulls off that fluid, any excess fluid, or any fluid for that matter. Digitalis, or DIG. Keep in mind with DIG, the patient develops nausea and fatigue. They're probably going into DIG toxicity. What else will they see with DIG toxicity?
Green halos.
Green or yellow halos. And they will be bradycardic. They could very well be symptomatic bradycardic. So we would check a DIG level. Now our inotropic agents that we would give for these patients. Now if a patient comes in and their BNP is elevated in the high hundreds, in the thousands, the patient's in congestive heart failure, there are a couple of options. So we have our Nesurtribide, however you like to pronounce it, which is NitroCore for trade name. Then we also have generic name of Primacor. Then there's another one that we can also give, old favorite, butamine. So these are the inotropic agents that can help with the pump. In the hospital wise, they're infusion for about 24 to 72 hours depending on the patient. To help with that pump is the goal in those medications. Keep in mind too with the diuretics, of course the diuretic of choice would be a loop diuretic. It's potassium wasting. Keep an eye on that potassium, which you guys know that already. So that should be nothing new for you. So assessment, listening, seeing, hearing, all that stuff plays a role with assessment. Diagnoses are associated with it. Complications, all self-explanatory. When we get into patient teaching, reminding these patients that they have heart failure, even if they're not in congestive heart failure, that they need to reduce their sodium intake. Because again, we know already that where sodium goes, water follows, and that's how they retain that fluid. Fatigue mentioned, fluid overload mentioned, and so our goal is to prevent that from happening. And reminding our patients, with teaching purposes, to avoid the sodium or the salts. And those hidden salts that they may not see, right? It's not just the table salt they put on it. It's all their processed meats, and any canned foods, because the preservative in canned foods is sodium chloride. So, of course, I'm reminding them ketchups, mayonnaises, and those are high in sodium as well. Pulmonary edema. Moist, noisy respirations. The sputum would be frothy. We'll hear crackles as we stated earlier, or was stated earlier. Prevention is the key for the management of pulmonary edema. Medications of choice would be your furosemide, your loop diuretic, and morphine. Morphine decreases venous congestion. So it's definitely, now keep in mind, side effects. Hypotension, actually from both of these, we're giving them in a combination. Hypotension, and then of course, decreased respirations. These patients on pulmonary edema should also be on an ECG monitor, so we can keep an eye on that. Because this is one of the causes, too, that could happen, not only the heart failure and the pulmonary edema from having an MI. So that leads to cardiogenic shock. So, inadequate tissue perfusion or failure in the pump. Two devices that could come along with cardiogenic shock is a left ventricle device, or also known as an LVAD, or an implanted cardioverter defibrillator, also known as an AICD or an ICD. You'll see it both referred to. When it first came out, it was AICD, and then now they dropped the A because it was automatic, and that's what the A stood for. So, and that's to prevent any VTACs or any lethal rhythms with having that implanted cardioversion defibrillator. So, management-wise, for cardiogenic shock, is inotropic agents. Not only could one of these be used, but also if they're having hypotension, we can also bring out the dopamine or the Levophed, which is norepinephrine. But assessment-wise on these patients would be important. Fluid status, checking dysrhythmias, and then knowing the actions of the drugs that are associated with what they need. Another thing that they could use is an intra-aortic balloon pump. Here's a picture of what, just for visual purposes, of an intra-aortic balloon pump. You will see in diastole it is inflated, and systole it's deflated. When patients are on a balloon pump, it is a one-on-one with that nurse. One thing that you will also see with these patients is their extremities will be pale in color, or more darker complected would be darker. Our peripheral pulses will be faint. They're not going to be bounding for sure. Because the main goal is to keep that core blood flow. But again, horribly pale or darkened because of perfusion. Perfusion. One thing that also we mentioned for complications was pericardial infusions or cardiac tamponades. So definitions are there, even though we touched on them briefly. Pulse-6 paradoxus in the clinical manifestation is one of the definite symptoms or signs that we see. Now it's hard to see unless they have an art lane, but by the time these patients come to this point, they already have an art lane because they're probably not hemodynamically stable. So we will notice with the systolic blood pressure decreases when the patient inhales. That is pulsus paradoxus. So when they inhale, their systolic blood pressure decreases. So again, we can see that arm on our art lane. How do we fix this pericardial infusion and the cardiac tamponade? One is a pericardial centesis. It's needle aspiration to get that fluid out of that pericardial sac. The other option would be a pericardiotomy, which is a window. They will actually cut a window in that pericardial sac to then, for lack of a better word, suction. I was going to say vacuum because that's really what they need to do is like a shop vac. Is get that, if you've ever used a shop vac, you know what I'm talking. It sucks really good, right? And so they need to get that fluid out of there. But then we'll of course worry about infection. So again, just to remind you of what your Torsades de Pointes looks like on cardiac monitor. Remember, looks a little V-tackish, V-fibbish, V-tackish, V-fibbish, V-tackish, and so on. So twisting of the points, Torsades de Pointes. Again, this is what we see caused by the pericardial effusion leading to that cardiac tamponade of that squeezing. So, a reminder or refresher, with sudden cardiac death, we know it's ABCs, right? Airway, breathing, circulations, we defib, VTAC, VFib. Shake and shout. When we see a patient that has suspicion of sudden cardiac death, we go back to the basics. Everybody wants to move forward, right? We all want to get to the ACLS protocols and give the drugs. But we got to go back to basics, starting with a basic life-saving. You shake and shout. Hey, hey. Annie always gets picked on. Annie, are you okay, right? Or John, or Jim, or whoever the person is. You want to shake and shout. Getting back to the basics. Questions about that? All right, let's go ahead and take 10 minutes. 9:05.